Thank you for inviting me to present at the Colon Cancer Foundation's Early Age Onset Colorectal Cancer Summit of 2021. It's my pleasure to give this lecture to try to understand, how did this happen? How do we investigate the causes of early onset colorectal cancers? I'd like to begin with the story of a patient whom I had the great privilege of caring for, that you see here, who is a young woman diagnosed at the age of 28 with colon cancer that led to metastatic disease and, unfortunately, her early demise. This wonderful, inspirational young woman had absolutely no risk factors for colon cancer. And despite all of our best efforts to understand how she developed colon cancer, and recognizing that colon cancer screening is not recommended for individuals at very young ages on the basis of the fact that it's still a relatively rare disease, what I'd like to do with you today is explore some of the things that may help us better understand the trends and the changes in the incidence of early age onset colorectal cancer, as well as some of the factors that might be contributing to why this disease is increasing. Let's begin by thinking about a specific diverse area of the United States that we've had an opportunity to concentrate on here at the City of Hope National Medical Center in Duarte, California, as well as work from the USC Norris Comprehensive Cancer Center in Los Angeles. And the Cancer Surveillance Program of Los Angeles has been studying trends of colon cancer in this very diverse community for decades. What that allows us to do is to be able to understand trends over time in a diverse population with many different age groups and many different racial and ethnic backgrounds as well. And specifically, some of the work that's been able to be better clarified and quantified with respect to the trends among adolescents and young adults gives us the ability to understand specifically how colorectal cancer is changing in adolescent and young adults. When we think about early age onset colorectal cancer, let's just begin with some definitional opportunities. Many people consider early age onset colon cancer anyone who's diagnosed below the age of 50. And when you read the literature and try to understand what types of trends we're examining more closely, the literature includes the study of adolescent and young adults, which often is defined as those aged 35 and younger, or sometimes it's defined as those 40 and younger. And you'll see that several of the studies that I reference throughout this particular talk will use different age criteria. But in general, we're talking about those who are diagnosed at a much younger than average age. What we do know that is that the rate of colorectal cancer increases both within age, in other words, in young adults, as young adults age, their risk of colon cancer increases. But more importantly, what we've seen are some very important increases in the rate of colon cancer over time. And as we look at young adults who have developed colon cancer in the period from 1988 to 1991, as well as all the way through 2007 through 2011, you can see that in both males and in females, those rates have increased quite substantially. So on the left-hand panel, you'll see that the risk of colon cancer is very, very low below the age of 15. But it in fact does increase with age-specific incidence rates approaching 8 per 100,000 per year by the age of 40. And that's nearly a linear trend associated with increasing age. But what is more startling to many of us is the fact that it's changing over that period of time from the 1980s to now in the 2020s. We also note that the age-adjusted cancer incidence differs by both race and ethnicity. And here, as we look at the age-adjusted incidence rates by race and ethnicity for adolescent and young adult carcinoma of the colon and rectum in Los Angeles County, we can see that those rates do differ. Now, these are relatively small numbers, but one of the things that you can tell is that the blue bars, which represent the incidence rates among males, are generally higher than the incidence rates among the red bars that illustrate the rates in females. And that's certainly true globally. The rate of colorectal cancer is slightly higher in males than in females. But we can also see some very important trends by race and ethnicity, recognizing that there are populations in whom this has a disproportionate burden, including the Black American community, the Vietnamese community, the Korean community, and in non-Latino whites, it is also clearly a burden as well. The data that we see in Los Angeles are reflective of national trends. And I just want to point out nationally what we know about the rate of colorectal cancer incidence, and that is it's declining. We actually know that nationally, over the past 30 to 40 years, we've actually seen important and meaningful decreases in the rate of colorectal cancer across males and females in many, many populations. But this is, of course, averaging across all age groups. So this decline is not shared proportionally by young adults. So let's concentrate on the data from the National Cancer Institute SEER program just to look at young adults. And if we look at the incidence rates of colorectal cancer for early age onset colorectal cancer, in this case defined as anyone diagnosed below the age of 50, we look across all the surveillance epidemiology and end results registries in the United States, we see that for both males and females, there's been a remarkable increase in the incidence of colorectal cancer since about 1995. So over that 20-year period of time when we have seen declines in the incidence overall, we are actually seeing an increase in young onset colorectal cancer. Let's examine this just a little bit more carefully so that we can also examine survival. When we look at survival among adolescent and young adult survivors of colorectal cancer, we can look at it by a number of different strategies and a number of different ways to stratify these data. The distribution and survival probabilities can be examined by patient or tumor characteristics. And here I'm just going to concentrate on a limited subset of the data that is shown in this table. The first of which I'd just like to point out that the age group is those diagnosed between the ages of 15 and 39 in this data analyzed from the Cancer Surveillance Program in Los Angeles. So these are even younger patients than we saw in that national SEER program. And those that are quite young, those between 15 to 24, represent only about 6% of the individuals diagnosed with early age onset colon cancer. But let's look more closely at this group here. If we look at the percentage of cases diagnosed between 15 to 24, it's quite small. 25 to 34 represents about 40% of all early age onset colorectal cancer patients, and 35 to 39 represents a much higher fraction. But let's also notice that these survival probabilities are quite low, and indeed we are concerned that the 1-year survival for the youngest of the individuals who are diagnosed with early onset colorectal cancer is always lower than in those groups that are 25 to 34 or 35 to 39. And here you can see 1-year survival rates are lower than in those older age groups, 3-year survival rates are lower, and 5-year survival rates are lower in that youngest age group. We'd like to be able to better understand why those survival rates are younger. And Mariana Stern, Afsani Barzi, and others have been able to look at this through data from the LA Cancer SEER surveillance program. And one of the things that is clear is that survival rates decrease for individuals of lower socioeconomic status who have early onset colorectal cancer. And here we look at the observed survival probability among adolescent and young adult individuals with colorectal cancer. By socioeconomic status, what we can actually see is those with the lowest socioeconomic status have the lowest survival. This is not surprising to any of us who care for patients with colorectal cancer and see the burden of cancer in our community, recognizing the disparities that we still so desperately have to address. But here we can see that the highest survival rates are associated with those with the highest socioeconomic income. Now, let's look beyond our data here in Los Angeles to understand how mortality rates are changing nationally. And nationally, despite the fact that mortality rates are also declining over all age groups, mortality rates are rising for early age onset colorectal cancer. And specifically, we see that for both males and females, although it's somewhat attenuated in females, we do see that colorectal cancer mortality rates have been increasing over the past 20 to 25 years. Very recently, an important and valuable review paper was written in Nature Reviews Clinical Oncology by Dr. Akimoto and his colleagues, led by the epidemiology group at Harvard by molecular epidemiologist Shuji Ogino. And in this paper, they described the rising incidence of early onset colorectal cancer, calling it a real call to action, and recognize that it's not just a US phenomenon. Individuals diagnosed with colon cancer below the age of 50 has been increasing worldwide, and especially in high-income countries. I'll just highlight one of the most important lessons that I have appreciated in putting together these data and thinking about it for many years with many of you. The reasons for this increase remain unknown. We don't know why cancer is increasing in this group. And as we think about all the possible explanations, including Western-style diet, obesity, physical inactivity, antibiotic use, especially in the early life period of time, it's not clear why this incidence and epidemic of early onset colorectal cancer is being observed. What Akimoto and colleagues suggested was a framework to help think about this, where they examined a number of different types of risk factors that could be examined across the lifetime and lifespan, including even prenatal exposures that could be related to things like reproductive technologies or in vitro fertilization, parity, infancy, childhood risk factors, adolescent risk factors, or even risk factors in adulthood. As we have spent most of our time as epidemiologists studying adult exposures. And as we think about this exposome or early life exposome capacity to understand risk factors, there are a number of different biospecimens that we might be able to examine as well. And in this paper, they suggest that germline genetics and the microbiome might provide additional insights that would help us elaborate and understand causes of rising incidence of colorectal cancer. I'll also talk just a little bit about the fact that they postulate that gene-environment interactions might be an explanation. I personally think that it's unlikely for gene-environment interactions to be able to explain the differences that we're seeing in trends, but we'll get to that in just a moment. I'll also point out another terrific recent summary article that offered a perspective of early onset colorectal cancer published in Nature Reviews Cancer. And in this paper, there were several perspectives that were offered suggesting that what we really need to do is focus on the mechanistic studies that understand the biology of early onset colon cancer, specifically as it represents colorectal cancer disparities among young adults. Here's the framework that the Halatawaj group presented when they understood risk factors that could be classified into systems and institutions. Are there elements such as screening policies within healthcare systems that either contribute to early diagnosis or, in fact, failure to diagnose? The built environment that might contribute, including elements of the microbiome that might alter or change within family environments or other elements of our external environment, including recognizing and acknowledging the important factor that systemic racism can play in our inability to address these disparities. But then looking more specifically at individual factors that contribute, as well as biology and genetics. Let's examine genetics a little bit more specifically. Can germline genetics contribute to changing trends? So first, let's answer the question of how much do germline genetic syndromes contribute to early age onset colorectal cancer? And as we are all aware, young age of onset is one of the hallmarks of inherited susceptibility to cancer. And in fact, when we see early age onset colorectal cancer, one of the first things that we do is offer the possibility of a genetic explanation that can be explored with genetic counseling and genetic testing. And here I'm just listing some, but not all, of the syndromes that are most commonly associated with early onset colorectal cancer, including familial adenomatous polyposis, Lynch syndrome, and Li-Fraumeni syndrome as autosomal dominant syndromes. There are a number of other syndromes which are quite even more infrequent, or autosomal recessive conditions like biallelic MUT-YH associated polyposis. So these syndromes, which I want to explore in a little bit more depth to understand how much cancer they actually contribute to, is something that we'll review in the setting of a large series of registry studies as well as single institution studies. But these have been contributed by Henry Lynch, whom you see over here on your right, as well as the wonderful Fred Lee and Joe Fraumeni, who helped outline the spectrum of cancers involved in Li-Fraumeni syndrome. Matt Yergelin and Sapna Singhal at Harvard, along with a large group constituted by the Colon Cancer Family Registry, studied germline TP53 mutations in patients with early onset colorectal cancer within the Colon Cancer Family Registry. And in this study, they examined 510 patients with colorectal cancer that was diagnosed under the age of 40. 47 of them, 9%, had germline mismatch repair mutations, and about 1% had biallelic MUT-YH mutations. How much did Li-Fraumeni syndrome contribute to this particular group? Well, overall, 1.3% of this large cohort of patients with early onset colorectal cancer was found to carry pathogenic TP53 alterations. Importantly, none of those probands had clinical histories meeting the criteria for TP53 testing. So if they hadn't been tested on the basis of recognizing that they alone had early onset colon cancer, nothing in their families would have suggested that they would have met criteria for Li-Fraumeni syndrome. So let's just point out that 9% Lynch, 1% biallelic MUT-YH, and 1% Li-Fraumeni syndrome are relatively small numbers, even among individuals with early onset colorectal cancer. And now if we look at the data that were published from the MD Anderson single site study that was performed by Maureen Mork and led by Eduardo Villar and his group, along with Patrick Lynch and Miguel Rodriguez-Bigas and others. In this particular study, they looked at 193 patients with colorectal cancer that had been diagnosed below the age, at or below 35 years of age, who were seen at MD Anderson specifically for genetic counseling and testing. In their study, and remember, these are patients that had been referred for suspected inherited susceptibility, 12% had Lynch syndrome with a germline mismatch repair mutation that was identifiable. 11% had Lynch syndrome by clinical criteria but were mutation negative, and about 8% had familial adenomatous polyposis. 1% had biallelic MUT-YH mutations, and 1%, or about 0.5%, had Li-Fraumeni syndrome. So these data are actually quite consistent, whether or not it's single institution, whether or not it's a large national family registry over a longer period of time. What we're actually recognizing is that much of what we see is not easily explained by Mendelian cancer genetic syndromes. But let's take a moment to try to answer the question of whether or not population genetics is likely to explain the changing trends that we observe within this rising incidence and epidemic of early age onset colorectal cancer. I'd like to point out a paper that is just a classic in the literature of population genetics, written by J.B.S. Haldane, the famous Oxford geneticist, who wrote a paper in 1935 that described the rate of spontaneous mutation of a human gene within a population genetics framework. And what I'm going to show you is the way in which he described one specific example of how to understand whether or not population genetic frequencies can change meaningfully over time, and how we can understand what influences gene mutation prevalences in the population for diseases that are either in equilibrium or changing over time. Now, this is a little bit complicated, but here's the example that he gave. He used a single example of hemophilia as an X-linked autosomal recessive disorder to keep things as simple as possible. And I'll simplify it here, but these 4 sentences really summarize what is now known as the Haldane hypothesis. And what Haldane actually explained in this paper in a beautifully simple mathematic way is the fact that females have 2 X chromosomes, males have a single X chromosome, and for an X-linked lethal recessive disorder, one can actually calculate the loss of X chromosomes that carry a mutant allele for a lethal recessive disorder by simply recognizing that each generation you would lose 1/3 of all genes or alleles carrying the mutant hemophilia gene each generation. But the disease is in equilibrium. So if the disease is in equilibrium, the new mutation rate has to equal 1/3, so that there is replacement of the genes that are lost with each subsequent generation that loses a gene due to its fertility lethal nature. So without expanding this to all of the different circumstances that might apply to colorectal cancer syndromes, including those that are autosomal dominant, autosomal recessive, or even polygenic, I would simply like to postulate that I just don't think population genetics can possibly explain the expanded rise in early onset colorectal cancer that we are seeing over such a short period of time. There's just not enough time or not enough influence of factors that might impact the gene prevalence within a population to have any impact on what I believe we are seeing is a disproportionate rise in early onset colorectal cancer. So in my view, population genetics is unlikely to explain early age onset colorectal cancer. And that's one of the reasons why I think that it's even harder to imagine ways in which gene environment interactions in a more complex mathematical relationship could be explaining something that we are simply seeing as a rise in both males and females across many, many different developed countries where the incidence rate continues to rise for early onset colorectal cancer. So if not genetics, then what does explain rising incidence? One of my former students, who is now a tenured faculty member with her own research group, published a paper from our population-based study of colorectal cancer in Israel, examining modifiable risk factors for colorectal cancer that she published in the New England Journal back in 2005. And what Jen Pointer showed was that, as you know, there are a number of factors which make sure that we understand that genetics is not destiny. Aspirin is associated with reduced risk of colon cancer. So is physical activity. Statins, as we showed in this paper, is associated with a reduced risk of colon cancer in our study. Vegetable consumption, reduced risk of colon cancer. Alcohol was slightly associated with an increased risk of colon cancer, and a family history was also associated with a twofold increase in the risk of colon cancer. And as we look at larger studies that incorporate ours, including the CORRECT Consortium, the Colorectal Transdisciplinary Consortium, and the GECKO Consortium that's led by Ricky Peters, we can begin to examine all of the risk factors that have been assembled across hundreds of studies with tens of thousands of patients, recognizing that things like processed meats in terms of servings per day are associated with a slight increase in the risk of colon cancer. So is body mass index, alcohol, sedentary behavior, red meat, smoking, body mass indexes reflected by height, and in fact, cigarette smoking are all risk factors associated with small but measurable increases in the risk of colon cancer. And there are clearly protective factors as well, including calcium consumption, folate, vegetable consumption, fruit, non-steroidal anti-inflammatory drugs, and hormone replacement therapy. But I do want to point out, as we look at this, that if you were to examine a gene like APC that causes familial polyposis, or MLH1 or MSH2, where the relative risk is somewhere between 5 and 10, the relative risks on this particular graph would be so far off to the right that they would not even be able to fit onto this slide. So these relative risks are quite modest relative to what we understand to be the autosomal dominant forms of inherited susceptibility that we recognize are relatively rare, but in fact important. So what is causing this increasing incidence? And the bottom line is we don't know. But I want to explore the way in which environmental factors might in fact have changing trends over time and might be associated with risks of cancer, not as a specific explanation, but as one representative way to think about these constellation of risk factors that can have an influence. So let's just take a quick coffee break. Stephanie Stenzel, a faculty member at the Cleveland Clinic and a former student and postdoc in my group, brought to my attention a question which I had never considered. She said, do you think coffee could be associated with risk of colorectal cancer? And I couldn't imagine that it was either protective or a risk factor. But she said it might have a lot of reasons why it could impact the GI tract in a way that would influence the risk of colon cancer. And in fact, we looked at coffee consumption in our Israeli study and saw that coffee consumption differed slightly among several of the population groups in Israel, where Ashkenazi and Sephardi Jews consume coffee at a meaningful but relatively low rate relative to the Arab population. And indeed, they drink slightly different types of coffee and styles as well. But what Stephanie was able to do was examine what is the relative risk associated with coffee consumption and risk of colon cancer. And she found something quite remarkable. The more coffee people drank, the lower their risk of colorectal cancer. Indeed, the association was quite strong and had a linear trend, which suggested that there was a dose response. And I will also recognize the fact that it didn't matter whether or not the coffee was caffeinated or decaffeinated. There was still a meaningful reduced risk of colorectal cancer associated with coffee consumption in essentially all groups where we had the power to detect it, with odds ratios from 0.73, 0.75 to 0.66 and 0.66 for all coffee consumption, and even decaf coffee consumption was associated with reduced risk of colorectal cancer. These data were a little surprising. It led to a really interesting paper and a fair amount of press, but when we looked at hot beverages that were not associated with coffee, there was no difference in risk. Tea did not influence the risk of colon cancer at all. Other hot beverages that were not coffee were not associated. So it appeared to be quite specific. So that led me to think, just as a representative example, what are we seeing in terms of trends of exposures like coffee, which we recognize may indeed be a protective factor for colon cancer? And if we look at data from NHANES, the National Health and Nutrition Survey that's performed here in the United States, it's interesting to look at the trends of mean coffee consumption over time in different age groups. And it's actually quite low across all groups in 13 to 17-year-olds. And in 18 to 24-year-olds, you can see that it doesn't change much over time. But indeed, coffee consumption does appear to decrease from 2003 to about 2010, and even in 2011-12 is lower than it was in earlier eras. And in these data, they then look not just at mean consumption, but among those who drink the most coffee, does that difference decline as well? And indeed, they saw that there was a decrease in coffee consumption over time among those who drink the most coffee. There was also evidence that there was a little bit of a substitution effect, so that for those people that were drinking energy drinks, their coffee consumption was coming down. And one might postulate that, sure, if there's a protective effect of coffee, with coffee consumption going down, that might lead to a slight increase in risk, or as energy drink consumption rose slightly over time as a substitution of a caffeine source, perhaps that changed the microbiome in a way that is leading to increased risks. But I think it's actually hard to postulate that those risk factors by themselves, any single one, could explain the types of differences in incidence that we're seeing. So let's just recognize that that coffee break is over. But as we do look at the trends and patterns of caffeine consumption from NHANES, I'll just once again highlight the fact that in this particular analysis by Tran et al., a linear regression model of caffeine intake from energy drinks against caffeine from any sources, including coffee, tea, or soda, among the individuals who drank more than average caffeine, showed a statistically significant inverse relationship between energy drink consumption and coffee consumption, further supporting that substitution concept. So I'm raising that just as a simple single example of the many, many different risk factors that we've been able to recognize as all contributing, whether it's physical activity or other elements that we might be able to postulate. So we are now moving into an era where it's easier and easier to measure genetic susceptibility. And many of you are aware of polygenic risk scores that include the data as published by Stephanie Schmidt and our consortium that identifies numerous small individual loci across the human genome that contribute modest risk of colorectal cancer, but indeed does lead to the ability to generate polygenic risk scores that will improve our ability to recognize inherited susceptibility. But once again, I think it's also very hard to postulate that that multitude of genes, each of which is transmitted according to Mendelian genetics, would change meaningfully over the last 20 years. In fact, I would argue that it's almost impossible to think about a way in which hundreds of loci could all be influenced over a several decade period of time that would meaningfully influence the genetic susceptibility risk within young onset individuals that would predispose them preferentially. So I think it's actually less likely to be polygenic risk than polyrisk, which will include things like medications, physical activity, diet, and other changes in trends of risk factors that hopefully we will be able to explore with the same specificity that we are now better understanding through genetic studies. And it's going to take our collaboration and a lot of work to answer the question that we do not yet understand. Why is there an epidemic of early age onset colorectal cancer? And on behalf of my patient, her family, and all of those patients in the world who are suffering with early age onset colorectal cancer, this is a call to action we do have an obligation and an opportunity to understand why the risk of colorectal cancer is rising in early age onset individuals. More questions than answers remain, but I'm grateful for this opportunity to speak to you about it today. Thank you.